Mike Gibson of Summit Wazni, and we're here talking about the option trial. I think one of the more important trials that were released at AHA. We're getting to it a little late here, Summit. That's okay, though. Better late than never. Talk to us a little bit about what you did, why you did it, and what you found.
Thank you, Mike. This is, it's a pleasure to be with you here, and I'm looking forward to a lively discussion. So why did we do it? Let's start with the why. Why did we do this? Frankly, I mean, the why was because of the guidelines, and why were the guidelines the way they were? Because of the uncertainty. So let's talk about the guidelines a little bit, and then we'll go into it. So the guidelines tell us now that after an ablation, regardless of the outcome, whether you're successful or unsuccessful, you should continue oral anticoagulation or discontinue oral anticoagulation based on the CHA2DS2-VASc score. So a patient who has a CHA2DS2-VASc of 2 or higher, then they should stay on oral anticoagulation, whether or not they're having AFib or not. But you know that CHA2DS2-VASc really is for patients who have AFib. So if a patient gets an ablation and does not have AFib, I mean, there's no CHA2DS2-VASc here. But then the guidelines say you have to continue the blood thinners.
And why is that? How did we get there, Summit?
Exactly. So that's where, yeah. So why did we get there? Because there wasn't consistent data. There wasn't good enough data to tell us, do people, what happens to the stroke risk after an ablation? The other reason, and I think this is where the guidelines, they erred on the safe side, is because after an ablation, a lot of patients can have recurrence of AFib that's silent or asymptomatic. So now you have, on the flip side of what I was saying just now, the flip side is if you have a patient who has asymptomatic recurrence of AFib, and the patient feels, well, I don't have AFib, why should I take this medicine? Or even their doctor, but they truly continue to have AFib, and then you stop their oral anticoagulation, end up with a stroke. I mean, the stakes are so high, stroke that is, and that's why the guidelines came the way they came. But then what we were having in clinical practice is a problem. You have a patient who says, Doc, I mean, I thought I had this ablation, so I don't have AFib, so I don't have to take the blood thinner. And then we have to go back and remind them, listen, we did your ablation for symptom relief. We never said that we did your ablation so you can come off your oral anticoagulant. And that's where actually the concept of option started building. That was the nidus of the idea of option. It's like, okay, what if we have a solution and that will protect the patient from a stroke and not expose them to bleeding? And this is where, I thought, okay, well, maybe we can use Watchman. At that time, it was Watchman. There was no Watchman Flex to solve this problem and get us out of this uncertainty and ambiguity in dealing with this problem.
Great. So what did you do?
So then we said, okay, we're going to randomize patients, CHA2DS2-VASc 2 or higher in men, or 3 or higher in women. And we said, okay, let's randomize them to ablation plus oral anticoagulation versus ablation plus Watchman Flex. Now, it was a non-inferiority design. And just a reminder, quick refresher for people. The reason it's non-inferiority is that, like, why do people do non-inferiority designs? Because you have a new therapy or a new device that has some attributes that are better than the old therapy. But at the same time, you're not sure whether the efficacy is going to be the same. So for example, in Watchman, what are these attributes? One, less bleeding because they won't be on a blood thinner. Two, the other is compliance. Patients don't have to worry about taking a medicine. Three, maybe cost over time of taking oral anticoagulation. And four, again, bleeding, because you may have a patient who's 70-year-old today, but in 10 years, they're going to be 80 and they may start having problems. So you already addressed that issue early on. So that's why people do non-inferiority. On the flip side, the efficacy may not be as good. So we talked about, in the past, there's some issues like, okay, well, Watchman was approved not because it was better or even non-inferior in terms of ischemic stroke, but because it caused a lot less bleeding in those patients who are already bleeding. So those patients had bleeding issues. So that's the current indication. But also I want to remind people, and you, Mike, you know this, that even the DOACs were approved. They were non-inferiority studies that were non-inferior with respect to ischemic stroke, but was superior when it came to bleeding. And that's why they were approved. Plus, there was the other attribute, which is good about them, is you don't have to check an INR. Patients don't have to go back and forth to the Coumadin clinic. I think people forgot about the Coumadin clinic, but that's why it was not inferiority at the same time, because The attribute was you don't have to go to Coumadin clinics. You don't have to check INRs. Maybe there is less bleeding, but the efficacy they were not sure of. And that's why they were non-inferiority studies too.
So yes, those trials did end up showing they were planned as non-inferiority, but they ended up in a secondary analysis showing superiority on bleeding. When you put them all together, there was a strong trend, maybe positive in mortality. That's
Mortality,
because
yes.
bleeding strokes are actually just very disabling events, if not mortal events. So, here you have warfarin, and you're trying to get rid of an old drug that has very bad side effects, obviously, like bleeding. But as you said, you don't want to get rid of the good things like the efficacy in ischemic stroke reduction. Looks like things were pretty similar in terms of ischemic stroke reduction. The one exception is high dose dabigatran, which was superior
Yes.
to warfarin in ischemic stroke. So that was one that turned out to be superior. But you're right. I think for the most part, we tried to get rid of the bad side effects of warfarin, and we're successful with that.
So there was one other aspect of option we have to also remember is that in option, remember the Watchman, the original Watchman studies were against warfarin. I mean, so I think people actually should be congratulating us for doing, instead of criticizing us for doing option, because Watchman was compared to warfarin, the original ones. And that's how it won. It won because warfarin causes more bleeding. And we know that warfarin causes more bleeding than the DOACs, but there was no comparison between Watchman and the DOACs. So in option also, because it's the new era, 95% of the patients were on the DOACs. So it's actually a big risk for us because we thought, okay, now the DOACs have much less bleeding and major bleeding than warfarin. And now we're going to put it against Watchman. And then historically, like we said, Watchman won because it was warfarin, not the DOACs. Will it still win with DOACs? And so that's why I think we need to get a lot of accolades and, and people telling us good on you for being brave and
Great. And I think that's great.
to
You
do
did the
this.
right
Yeah,
thing.
yeah.
Yeah. So what did you find?
So we found, that the again it was a composite efficacy endpoint. So composite efficacy endpoint of all-cause mortality, stroke, and systemic embolism, and we found that Watchman Flex was equivalent to DOACs in those terms. And even so, 5.3 versus 5.8% event rate. But even when you take the different components of it, yes, it was mostly mortality, but still, even if you took ischemic stroke, for example, it was 1.2% in the Watchman arm versus 1.3% in the DOAC arm.
Now, hold on one second, Osama.
Yes,
This is, you said mortality was similar, but mortality was not was it part of the composite or was it just
it
strokes?
was. It was part of the composite.
Well, I think that's good because I've been pretty vocal about combining ischemic stroke and hemorrhagic stroke in non-inferiority trials because these go in the opposite directions,
Yes.
and you could reduce hemorrhagic stroke tremendously. If I use coffee here's my coffee cup with my dog Piper on it. If we use coffee, well, we wouldn't have any bleeding, but we'd have more ischemic events. So you can get into non-inferiority creep if you aren't careful. Now, um, one of the limitations of the stroke systemic embolization endpoint is that it didn't include mortality in the past.
Mm-mm.
I think that's a tremendous advance. I look to a world where we would have other bad endpoints like fatal and irreversible endpoints. So, as a patient, you want to be alive
Yes.
and you don't want to have an irreversible harm event. So, what are some of those irreversible harm events? There are things like an ischemic stroke, an MI, pulmonary embolism, if we're in the world of
Yeah.
anticoagulants. But over on the safety side, did you have a fatal bleed or did you have an ICH? You don't want
Yeah.
those. So I'm thrilled that you used death in there because this doing stroke systemic embolization doesn't include death. So congratulations on using death. And then you did do what I've been pounding in recent editorials to separate ischemic stroke and hemorrhagic stroke. And
We
here
did.
you saw the numbers were quite small, right?
Yeah.
But tell us the numbers.
So so a ischemic stroke was 1.2% in the Watchman Flex and 1.3%. But again, there were 9 events in the Watchman Flex and 10 in the oral anticoagulation group. So low in both groups. A hemorrhagic stroke was the same, 0.4%, so 3 in each group also. And then one of the criticism was, well, because it was all the non-inferiority was driven by mortality, which was 3.8 versus 4.5%. So 3.8 in the flex and 4.5% in the oral anticoagulation. But like you said, Mike, maybe you want to know that also the intervention is not causing death. People say, oh, well, why did you combine them all together? Because one,
One of my criticisms, Osama, was that by using stroke systemic embolization,
yeah,
you don't capture fatal
exactly.
GI bleeds.
Yeah,
Fatal GI bleeds weren't accommodated in
yeah,
that kind of scale. So, when you add mortality, and I'm talking all-cause mortality,
yeah.
that accounts for some of those fatal bleeds, which in previous studies was not accounted for. So I
Mm.
congratulate you on
Thank you.
including that because I think it does capture some of the very mortal bleeding events. Now I don't know why the people were dying. Very well, I ran the Pioneer study where we compared a DOAC to warfarin.
Mm.
We, of course,
Mm.
won on bleeding, but the
Yeah,
criticism was the same as it is here. Well, those ischemic events, you were underpowered there. But like you, we enrolled 2,200 patients. It took 5 years because it's, hard to find people who have both AFib and need a stent.
yeah.
So what we did in a simultaneous publication is we used all-cause hospitalization for some kind of ischemic event. So stroke, systemic embolization, plus
Mhm.
all-cause
Yeah,
hospitalization for ischemia. And when we did that, we actually showed that the DOAC strategy was superior. So the idea being that if you lump in some additional pretty hard endpoints, I mean, patients want to be alive, they want to be out of the hospital. So
yeah,
are you alive? Did you have some fatal disabling event? And were you out of the hospital? And when we have that broad range of outcomes, we showed superiority on the efficacy side. So I hear a lot of people complaining about, well, we can't get it done. And, look, I faced the same thing, 2,200 patients. It would have taken us 40 years to enroll 20,000 patients. So I think what we need to do is perhaps expand and use some hard endpoints, but maybe more of them in this field. And then one of the other criticisms was the non-inferiority boundary. I've written editorials about this. When you use an absolute non-inferiority boundary, things can get strange because here you were expecting a 10% event rate. You had a 5% event rate, and the non-inferiority margin was 5%. And so people have said, well, you can't even have, it's virtually impossible to have non-inferiority in that scenario. So what I've suggested in editorials is we got to go back and use the relative risk that was anticipated. So the hazard ratio would have been 1.5, 10% event
yeah,
rate,
yeah.
5% margin. When you use a relative or ratio or hazard ratio 1.5, did you achieve non-inferiority?
Yeah, so like I said, we did do the 1.5. I don't know that we published it or we shared it with people, but I mean, I have to go back to the statistic, but we did it and it still achieved non-inferiority, even with the relative ratio. So
Great,
actually not too concerned with that because well, I'm concerned, meaning I'm not concerned because it did reach non-inferiority, but also if you look at the numerical number, there were less events in the Watchman Flex group versus the oral anticoagulation. So again, 5.3% versus 5.8%. I mean, it
right,
was so non-inferior. I don't know if this is appropriate to say in a scientific forum like this. It was so non-inferior that maybe it was superior. I don't know because the event rate was low. Now, some people say, well, it's just a draw of the luck that it was 5.3 versus 5.8. But again, the margin, it's important also to remind people about the margin.
right,
Why did we pick 5.8? It was based
right.
on what we knew. I mean, what we knew from previous studies and previous data, and that's why we picked the 5%. But even if we had picked 2%, we would still have been met non-inferiority. I mean, when I saw this, it's like, okay, so just for people also to understand that suppose it is 5.8%. So if we reach 10.8% or 10.7% event rate in the flex arm, we would have said it's still non-inferior because it was still below that 5% margin. And we're way off to the left of that margin that I don't think that here there is something to say about, well, it barely missed the non-inferiority.
So basically, if it's unity, you were over here
Yeah,
better than unity, and the non-inferiority margin is over
it's
here.
over there,
It's
exactly.
at 1.5, and you're over here
Yeah,
trending, not significant, but
yeah,
on the right side of unity. So it's quite a ways over to that
yeah.
non-inferiority margin. So I think that's reassuring.
Reassuring, exactly. Yeah.
Um, and you know, where do you see this then fitting in? What is the change in
So,
practice after
so
this?
what we didn't get into, but we'll say it quickly, there was another endpoint, and this is the primary safety endpoint, which has to do with bleeding. Now here, it was also non-procedural major bleeding and clinically relevant non-major bleeding at 36 months. So it's important here to remind people what is clinically relevant non-major bleeding, and that means that the patient had to seek medical help.
Now, when you say that, I'm going to be a stickler here. I'm going to be
Yes,
stickler about a few things here.
yes,
First of
yes,
all,
yeah,
clinically relevant non-major bleeding. I wrote the BARC definitions for this, and
yes.
was it just that you had to go see someone for even a diagnostic test, or was it that the healthcare professional had to act on information? So, in the gradient of clinically relevant non-major bleeding, where did this fall?
So I don't have the exact details because you remember it's three things. It's one, you had to have a face-to-face conversation with a doctor. But this, I
Right.
mean, this is we should not trivialize this either because you have to make an appointment, you have to see somebody, and in this day and age, this is not something that is trivial. Two, they
Right.
had to change the medicine or they had to do an intervention for them.
Well, that's the point I'm trying to make, is that there was an intervention of some
Yes,
type by a healthcare professional. So
yeah.
it's just not like I called up and I got a bruise.
No, no,
That's
no. It was a
that's at
face-to-face.
the
Yeah,
that's at the very wimpy end of
yeah,
clinically.
yeah,
This
yeah.
is more real clinically
More
relevant.
robust. Yeah, yeah,
Yeah.
no, it was more robust. And they had to have healthcare utilization, basically, not just calling, oh, I got bruised or whatever. So,
Now let me ask you this. Here's my
yes,
second question.
yeah,
I'm pretending today that I'm an FDA panelist. So
yeah,
you analyze bleeding based upon the first line in the results section said the results were analyzed using an ITT analysis. So for bleeding, we use a per protocol analysis or as treated analysis because it's really based upon
yes.
exposure to the drug. You had to get the drug and you had to get exposed to it.
Hmm.
So obviously you won on your ITT. Did you win on an as treated or
Yes,
protocol?
the results were the same,
Great.
basically the same. And it's in the supplement. And we didn't have enough space to put it in the main. We wanted it actually in the main
I know. Look, I've been
manuscript,
there. I know
but
there's
there
so
was
much.
no space. So then they said to put it in the supplement.
Got it.
But with the sensitivity analysis, yes, basically the same results.
Okay, now here's the last question. You know what I'm going to ask you. You excluded periprocedural bleeding, and
Yes,
if you included periprocedural bleeding, how did you do?
and it was non-inferior. It was non-inferior. But let me just I want to qualify this a little bit to remind people. So remember, when patients need a um, a watchman or an ablation, they have to be on our oral anticoagulation. So even the procedural bleeding, I mean, was so low. If you remember the original Watchman trials, when you go at time zero, the procedural bleeding rises up and then the bleeding stops when you include the bleeding. If you look at our curves, even procedural bleeding was very, very low. Again, a testament to us, to the interventional community where we're using ultrasound, we're using all of this and other things to minimize procedural bleeding, intracardiac echo and CEE. But if even, so those patients who are getting the procedure, they're oral anticoagulation. Remember, they're going to stay on oral anticoagulation for 3 months. So even with that, uh, the procedure bleeding was very, very low.
All right. You've reassured me on all my, sorry, that's what I'm here for is to
No,
pressure.
no, it's good. No, 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 I'm happy that you bring it because out of this, you're giving me an opportunity to, in a very scientific forum, address all of these issues once and for all. Thank you very much.
Now, did you look at device-related thrombosis? Were there echoes done? Do we know
Yeah,
anything about
yeah.
that?
So there were device-related thrombosis. It was 1.9% at 1 year. There were some leaks, also higher than we thought. There will be, but it had the leaks. Let me talk about the leaks in a little bit, because 16% of the patients in of course, in the device group, because that's where we're looking for leaks, had CT scans, which we may be more sensitive than TEEs. And the early leaks were the same as Pinnacle Flex, for example, historical. But at 1 year, there were more. And I think it had to do with more use of CT scans. Now, the DRT,
So
what?
that, educate me, Osama.
Yeah.
Are CTs more sensitive than echo?
It is well, because there's no uniform way of reporting in the CT scan. So even you may see some contrast behind the device and say there's a leak, which is there is. I mean, there shouldn't be contrast. But is it a very big leak? Is it like could you see that channel? It's very difficult. Even from our cases here, we can't see that channel. So I think that's why it's much more sensitive than TE, because in TE you have to see a channel and you have to see flow before you say there's a leak.
All right. Well, where do we go from here? I mean, what is the future? We have evolution on both sides, right?
Right.
We have the Watchman Flex. You and I have been working together on some of this. There will be new generations with new coatings on your side. There will be new aprons and everything to minimize leaks.
Yeah.
So that'll continue to evolve. On the drug side, we'll have some new generations of drugs like factor 11 inhibitors and others. So how do you see all this shaping up?
So, I just want to, another thing that's reassuring, despite the leaks and the DRT, the risk of systemic embolism or stroke was very low.
Hmm.
I mean, so that's very assuring, meaning that they were minimal. Now, where does this go? I mean, this really, people, when I was giving the talk at the AHA, they asked me, so now we're going to implant everybody with a Watchman after an ablation. And I said, no, I mean, it's an option, it's a choice that we can discuss with the
Hence
patient.
the name of the trial, option.
I know, exactly. So it is something that we can discuss with the patient. I'm not saying, and I'm not advocating that every patient who has an ablation, we should go in and put in a Watchman. We should have a good discussion with the patient and decide together based on the risk profile of that patient, whether this is something that would be reasonable or not in the long term. Yes, there is going to be an uptick in use. I agree. And the FDA, I mean, this was again a trial that was designed with the FDA. So the results are very assuring. They may give an indication. But even with that, I think we should be, thoughtful about it. We should approach it in a way that, yes, this is a choice, and we should use it in select patients. Now, how selective or restrictive, that's a different story. I can't go into it. Now, the other good news is that we're all getting better at ablation itself. So less burden of AFib will help our patients, which came out with option. So that's very good. Two,
Even completely new techniques. I mean,
exactly,
yeah.
new techniques. Then number two, that the design of the devices is improving, so we'll have less DRT and less leaks. And then finally, number three, in the right patient, like I said, if you can do it together, because we didn't talk about this yet, but 40% of the patients got a combined procedure, meaning we did the ablation and at the same time implanted the Watchman Flex. We've been doing this in indicated patients, currently indicated patients, at the clinic since 2017. And I think that's the right thing to do in the right patient. Like if you have a patient, then do the ablation and close the appendage. Very low risk for the patient. So that's where I think this is going. Now, from the surgical literature, they're even going further. So there is now a study that's being, thought about in surgery, is that even a patient who does not have AFib, but they think the risk of AFib in the future is very high, they're going to clip their appendage. Yeah,
Yeah,
it's interesting. I mean, it's amazing that they can do that, and here we're like nitpicking on little thing. Yeah.
educate me, Osama. Why didn't the thoracoscopic approach to doing that take off?
I think because it's surgery. It's still the recovery from that procedure is still more than doing, for example, now a Watchman where we can go and the patient doesn't even feel that they. I mean, a lot of patients tell me, "Did you even do anything?"
Mhm,
Because they come out, they're like, is that it? Are you sure you did something? You put in a device? Like, yes, we did. And that's how it's supposed to be. So
mhm.
that's why I think, and it needs more resources for surgery and all that. Um, Now, but I think it makes sense, now that we're seeing this, that, in the right patient, again, in the high risk patient, it makes sense for us to adopt such a strategy.
You see a world where we would be taking best of class on the device side and best of class on the pharma side, where we would combine, a Watchman with a low dose of a DOAC,
Mhm.
or in the future, a low dose of a factor 11 inhibitor. Factor 11 inhibitors blocking thrombosis from contact activation, like what we're seeing with these devices. Or I'm even thinking very futuristically, I call it factor 21 inhibition, where you combine a 10 and 11 because they work in kind of different ways.
Mhm.
So, can we smoke the peace pipe? I mean, is this an all or none decision?
No, no. So I agree with you, Mike. I mean, I think, in the future, we have now a study going on. It's called LAOS 4 in very high risk patients. We're going to we're randomizing patients to oral anticoagulation versus oral anticoagulation plus Watchman. So trying to mimic LAOS 3. And I think that's a very, very, good development and evolution of where we're thinking. Now, with regards to even option patients, for example, if you have a patient who's really very high risk and they have other reasons to, or strokes that can come from other places, like a very big atrium, very large atrium. We know that sometimes clots can develop in the atrium. There's nothing to tell us that, okay, in the right patient, we can't go in, do an ablation, close the appendage, and keep them on oral anticoagulant, whether normal dose or low dose. But the good news is that it's like suspenders and belt. If they have a bleed or they get older and now they're falling, they have something to fall back on, which
Yeah,
is closure of
exactly.
the
Yeah,
appendage. Yeah.
exactly. Let me also ask you this. I had a relative who had an ablation procedure, uh, called me up, had an Apple Watch on, and said, I think I'm back in AFib. And I came over, looked at the watch. We did the single lead EKG, and he was back in AFib. Do you see a strategy where a wearable would guide, some of this anticoagulation and long-term care? I mean, where do wearables fit in monitoring after an ablation?
So I had a debate about this at the HRS. And I think wearables are good, but the problem is what is the lag time between when you get the notification and to act on it. Even in patients who have loop recorders, if it's the weekend, somebody has to act on it. And then also remember, so you had to go over there and confirm and see, and then say, depending on the chat's VAS, you need to get back on that blood thinner. Now imagine if your relative had a Watchman. You say, who cares? You have a Watchman. We can wait. Let's see, know what's going on. And then you drive it by symptoms, correct? So that's where I think closing the appendage is helpful. And the other thing, I mean, what's happening with my patients is really they're becoming obsessive compulsive. They're checking their watch all the time. Some people wake up in the middle of the night to check. I mean,
Mm,
how is that good for the patient? And then the watch still needs to be recharged. So and then again, a strategy that as long as the patient is asymptomatic, they're protected. Why not?
yeah. All right. Well, I usually go 3 minutes. We went way over that, but I do think this trial was so important, and has had so much, hallway chatter about it, and that I thought it was important to get you on and go through it in detail, talk about every issue that's come up and have you address it squarely, which you did. So thank you for joining us today, and thanks to all everyone in the audience who sat through all of this, hopefully, because I thought it was a great conversation, Osama.
Thank you so much, Mike. Thank you. Great to be with you and looking forward to more working to you or with you. Thank you.
Great.
All
Thanks,
right.
Osama.
Thank you. Take